Good evening, everybody, and welcome to this evening's Twilight Online Tackling Childhood Obesity Part 1 webinar. My name is Samantha, and I am your host for this evening. Before we make a start, I'd like to just make a quick acknowledgement of country. We recognise the traditional custodians of the land and sea on which we live and work, and we pay our respects to elders past and present. So I'd like to introduce our presenters for this evening. We're joined by our presenter, Dr. Natalie Cochran, and our facilitator, Dr. Jessica Watson. Natalie is a GP at Mount Druitt Medical Centre in Western Sydney, where she's worked for the last 4 years since completing her fellowship. Natalie has a strong interest in child's health and preventative care, and most recently has been a member of ACI's Diabetes Task Force. And Jessica is a GP in the Nepean Blue Mountains and the team doctor for the Australian Dolphins swim team. So welcome, Natalie and Jessica. Thank you for joining us tonight.
Thank you. Thank you.
Alrighty, I'll hand over to our facilitator, Jessica, now to take us through the learning outcomes for this evening, and then we'll get on with the presentation.
Good evening, everyone. Just to start off, we'll go through and highlight the learning outcomes. By the end of this online QI and CPD activity, you should be able to utilize current prevalence data to understand childhood obesity in different cultural and socioeconomic contexts, identify how socioeconomic factors can contribute to health inequalities for children above a healthy weight, assess a child's weight status as part of a routine growth assessment. Some of you might have softwares that already do that, but if you don't, we'll go through that later on in the talk. Discuss children's growth and provide advice to families in a culturally sensitive way while taking into account the context of social disadvantage. And I'll let Natalie go through the New South Wales Premier Priority.
Yes, so in Australia, there are many initiatives to address childhood overweight and obesity rates, and we will link to state-specific resources at the end of this presentation. Improving childhood overweight and obesity rates is one of the key Premier's priorities. It has been identified as a priority due to its links with psychological, social and health problems. Just to give an overview, the Premier's priority started in 2015 with the aim to reduce the rates of childhood overweight and obesity by 5 percentage points by 2025. This involves a multifaceted approach, as can be seen on this slide, and we are approaching this problem from many angles. It is a very complex problem. There are a range of programs influencing childhood settings like school and daycare, social marketing campaigns, and projects to change the physical environment to better promote physical activity and access to healthier food choices. The top left box on this slide shows a particular push to embed prevention and management of childhood obesity as part of routine clinical care. From now, all New South Wales health facilities are working towards the measurement of height and weight of all children and to provide families with advice and referrals where appropriate, such as to programs like Go for Fun and Get Healthy. Part of this work also involves referral to treatment programs and will also involve referrals back to GPs. So what is the role for GPs? General practitioners play a crucial role. We know that GPs are one of the most trusted sources of information for parents. GPs are commonly the first and sometimes only point of contact children may have with the health system, for example, at routine childhood vaccination visits. GPs often treat the whole family so they know the child in their family and social context and can provide continuity and care coordination. GPs are very experienced in managing many chronic illnesses, for example, diabetes, and GPs are in a position to assess and treat the health of a whole population due to the large volume of patients that they see, and GPs are starting to see their role in population health management more and more. GPs have an established role in preventative health activities, as we're well knowledge with the RSC GP Red Book, and good preventative care is very important as what happens in a child's first few years of life will have a profound effect on their health as adults. So just so we're all understanding, these are the weight status definitions that we'll be using throughout the talk. This language has been extensively tested with children and their families. It's found to be easily understandable, conveying a positive message and using a non-judgmental approach. The first definition is below a healthy weight, which is less than the 5th percentile. A healthy weight is the 5th to the 85th percentile. Above a healthy weight is the 85th percentile to less than the 95th percentile, and well above a healthy weight is the 95th percentile and above. It's important to note that language is used, and these definitions are used as a screening tool and a guide to the risk of health for the child, not as a label or a diagnosis, but as to assist in seeking improvements in the health of the child and adolescent, i.e. aiming to improve both their psychological and physical health and make them as happy and healthy as possible.
Childhood obesity rates have plateaued, however, are increasing disproportionately among disadvantaged groups, including culturally and linguistically diverse communities and those from low and middle socioeconomic backgrounds. Last year, the 2015 New South Wales School Physical Activity and Nutrition Survey data was released. Before we look closely at some data, I have a quick snapshot to help understand the prevalence differences for children from different backgrounds. What percentage of school-age children were overweight or obese?
So 1 in 4 children, about 24.5% of children and adolescents were found to be overweight or obese, with 7% of these children in the obese category.
Children of Middle Eastern background?
Compared to the general population, children with Middle Eastern background were found to have a prevalence of about 42.3%.
How does prevalence compare in different socioeconomic groups?
Comparing the highest and lowest socioeconomic groups, the highest socioeconomic status group was found to have a prevalence of only 19.3% compared to the lowest quintiles, which had a percentage of about 33.7%.
And for the Aboriginal and Torres Strait Islander children?
The rates of childhood overweight and obesity amongst Aboriginal and Torres Strait Islander children is around 30%. So we've all heard of the social determinants of health, whereas health and well-being of children is influenced by social determinants such as their family circumstances, school, community, and the built environment. And we know that there are many forms of disadvantage, and often individuals and families are impacted by more than one of these. For example, socioeconomic status, we can see that the lowest quintiles are characterised by factors such as lower employment and income levels, lower levels of education, geographical challenges, such as difficulty in accessing good quality healthy food. You may have heard of the concept of food deserts, where there's little availability of good quality fresh food and a high proportion of fast food and takeaway outlets in an area. We know that from some data that this is higher, these are much higher in areas of lower socioeconomic status, and worryingly, they are also higher around schools in areas of lower socioeconomic status. Things like availability of safe community places for children to play is also a factor. If you're from a rural or remote area, you might find that there's changes for preventative health program delivery that affects your access to health services, access to affordable healthy food, and reliance on private car use, private transport, and less active modes of transport. Health literacy, language and culture also have a vital role to play. It's more than just being able to read and understand a pamphlet or make an appointment, but it really looks at a person's ability to understand information and use it effectively to improve their health and apply it in their life. We need to make sure resources are available in patients' own language and is also culturally appropriate.
And Natalie, we just had a question come through as well, that those percentiles we went through at the beginning, just clarifying that they are based on the BMI for age. Is that correct?
Yes, that's correct. They're based on the BMI for age charts.
Perfect.
Okay, so the next slide is looking at a graph that displays the proportion of overweight and obese children and adolescents aged 2 to 7 divided up by age group and gender. This is important to have a look at this data, as we know that overweight and obesity is a major public health issue, second only to tobacco smoking as a risk factor contributing to the burden of disease in Australia. We know that overweight children are significantly more likely to become overweight or obese as adults. This graph gives us a breakdown of overweight and obesity for boys and girls by age. We're just going to have a look at this as a population view first before we start looking at more closely at our different priority groups. We can see here that the rates are steadily increasing across all age groups, and boys have a higher prevalence than girls, especially in adolescent boys. I think the key thing to note is that early intervention is critical. Children aged 2 to 4 years are experiencing obesity already, and as we will see later when we start discussing the data from the SPANS report, we find that parents are often very unaware of this problem. Prevalence is also higher in these age groups for boys versus girls. And also, as children become adolescents, the rates of obesity versus overweight starts to significantly increase, highlighting the importance of identifying these children with routine growth assessments so that we can provide the appropriate information to their parents and carers before the child ages and prevalence increases. This next graph shows the overall trend in the rates of overweight and obesity. We can see in general that overweight and obesity rates have been stabilising since about 2015. This overall would seem like a promising outcome. However, it's not the case for all groups, and we are seeing increases in some more disadvantaged groups, as we will see on the next slide. This slide highlights the social disparities in prevalence are widening. Those from a lower socioeconomic status backgrounds are more likely to be affected by overweight and obesity, and the gap is growing, the gap is widening. If you have a look on the graph, you can see on the bottom line that is for the highest socioeconomic status, and they are sitting at around 19%, and the rate of overweight and obesity has stabilised. The top line in blue highlights the group patients from the lower socioeconomic groups, and their rates of obesity is rising, and it's risen up to 33.7%. This is really important as it indicates that perhaps public health policies, whilst being effective in higher socioeconomic groups, not having enough impact in some of our socially disadvantaged groups, and we need to start addressing those obesogenic factors in those more socially disadvantaged groups. And data from other countries is also supporting these findings. Okay. So let's now have a closer look at some of the variation for children and adolescents above a healthy weight in socioeconomic groups and geographical regions. The children living in regional and remote areas are more likely to be above a healthy weight than those in major cities, as you can see here highlighted in red. Reasons for this health differential may include a geographical location, socioeconomic disadvantage, shortage of healthcare providers and allied health, lower levels of access to health service, and greater exposure to injury risks, and general and poor health of Aboriginal people who comprise a significant proportion of the population in rural and remote areas. We can also see on this graph that the prevalence of overweight and obesity amongst children and adolescents varies according to their socioeconomic status, with children in the lower socioeconomic groups more likely to be overweight or obese. For girls specifically, we can see here in the lowest socioeconomic groups, prevalence is as high as 38% compared with 24% of those in the highest socioeconomic group. This suggests that to achieve health equity, we need to think more about how we are addressing the health needs of these groups and the obesogenic factors that they face to improve prevalence rates for these groups. The next slide shows the prevalence of overweight and obesity rates amongst Aboriginal children. Aboriginal children and Torres Strait Islander children, as we have already seen, have significantly higher prevalence of obesity than non-Aboriginal children in Australia. Complex issues contribute to the higher prevalence. We know in New South Wales, factors like unemployment, education, incomes, multi-household families, and whether or not you rent or own your own house may have implications in the rates of childhood health and overweight and obesity. We also know that Aboriginal people may have a lower engagement with public health prevention initiatives, and it is important that we start addressing these issues by increasing engagement, by providing more culturally appropriate resources and programs, and engaging Aboriginal health workers to help deliver these messages. So this next slide looks at our COLD groups, culturally and linguistically diverse groups. As you can see on the graph here, if you're from an overseas background but born in Australia, the rate of childhood overweight and obesity is 27.7%, but it rises by 8% if you were born overseas. The most recent SPANS data supports this, and we can see that even in Middle Eastern backgrounds, and it's much higher, specifically up to 42%, and for boys from this population, it's up to 48%. So how many families in New South Wales speak languages other than English? The census data from 2016 shows that in New South Wales, there are a large number of families where households speak languages other than English. The 5 highest ranking cold population groups in New South Wales by language from the 2016 census data were Arabic, Mandarin, Cantonese, Vietnamese, and Greek. The top 5 countries of birth in New South Wales from non-English speaking countries are China, India, Vietnam, Philippines, and Lebanon. And this again highlights the need to ensure that patients and families have access to appropriate translated resources. And a lot of these can be found on ProHealth Professionals website, and we will talk about that more later in the talk. So these slides really start to look at the data in more detail, and very interesting to have a look at the breakdown here. This is from the SPANS report, which is the Schools and Physical Activity and Nutrition Survey, and this is encompassing all school-age children aged 5 to 16 years of age. The SPANS report breaks down a number of health behaviours, and unsurprisingly, children that were above a healthy weight are more likely to be carrying out behaviours that are putting them at risk. As you can see in the red, there are a number of health behaviours which characterise children well above a healthy weight. We can see across all BMI categories, things like vegetable intake is very low. We can see that children who are well above a healthy weight less commonly eat breakfast daily. They are more likely to drink more soft drink, for example, at least 1 or more cups of soft drink per day. In children that are overweight and obese, the rate is 12% compared to those of a healthy weight, it's only about 5%. Looking at physical activity, children that managed to get into the healthy fitness zone ranked at about 73% in those of a healthy weight status, but it halved to about 44% in those who are overweight and about 21% in those who are well above a healthy weight or obese category. The amount of children meeting the recommendation levels of physical activity was only about 25% in the healthy weight, but it falls to 16% in those well above a healthy weight. Across all the groups, we can see trends like high levels of sedentary behaviour, such as car travel to school, and high levels of screen time. We can also see at least 20% of children were eating takeaway foods at least more than once a week, and it was increasing up to about 30% in children that were well above a healthy weight. When compared this to the 2010 data, there were some improvements across things like vegetable intake, screen time, and takeaway intake overall, but in general, we've still got a lot more work to do. This next slide breaks down the data even further into locality, socioeconomic status, cultural background. We can see that children from lower socioeconomic and Middle Eastern backgrounds were less likely to eat breakfast. They were more likely to drink greater than 1 cup of soft drink daily. They were more likely to eat fast food and takeaways, and less likely to be in a healthy fitness zone and meet daily screen time requirements. Children from an Asian background were found to be less likely to eat fruit on a daily basis, less likely to eat a healthy breakfast. They were found to be the least physically active group, but they were managing to get good amounts of sleep and reducing screen time. Overall, we can see that there are more behaviours linked to overweight and obesity rates in the children from lower socioeconomic groups and those from Middle Eastern backgrounds. We can also see the higher prevalence of children with childhood obesity and overweight in these groups. Just to summarise, children from outer regional and remote locations are more likely to be above a healthy weight. Children from the lower socioeconomic status groups are more likely to be above a healthy weight, and Aboriginal and Torres Strait Islander children have a significantly higher prevalence of obesity than non-Aboriginal children. Just a few things to think about in practice. How can we help families prioritise health behaviours when there's other factors in play, such as being able to afford groceries or pay bills? We need to start looking at it from perspective of how can we help families access those services and programs that they need when they're already faced with other more urgent issues on a daily basis. And policies and programs need to be in place, and that's where the Premier's priority is, trying to address some of these social determinants of health. So these are some cultural considerations to think about in practice as well. We know that obesity is more likely to be culturally acceptable among children and teens from Middle Eastern and Pacific Islander backgrounds. We know that behaviours such as skipping breakfast, drinking too much soft drink, or being rewarded with sweets is also common. We know that low levels of physical activity are common and fast food intake is higher. There are lots of barriers for migrant communities, and this was identified by CALD parents in the study. You can see there's the Cyril study in 2017. These barriers included things like post-migration priorities like parental responsibilities, time factors due to work commitments, employment and housing, finances, lack of transport, access to a car, and difficulty catching public transport. Lack of family support was all listed as big factors that were affecting participation. Things like language barriers, the apprehension of joining groups that were from an English-speaking when you weren't from an English-speaking background, previous traditional dietary practices, cultural perceptions of food and weight, and cultural norms making difficulty to enact change were also listed as common. Health literacy was also an important factor. People reported that they did not have enough knowledge of food labelling in Australia and ability to understand the information that was being presented, and the lack of culturally appropriate and language appropriate information was lacking. Environmental factors such as living in areas where there are a high proportion of takeaway outlets versus fresh foods, advertising targeting children, and peer and social pressures were also listed as important factors. They also listed policy barriers such as difficulty navigating our health system and fragmentation of health programs. But enablers were listed as bicultural playgroups, school liaisons and initiatives, and community groups that were enabling and supporting patients to make changes. This data is really interesting and a really big consideration that we take into place when we're talking to families and parents about a healthy weight or if their child is above a healthy weight. This data comes from the SPANS report from 2015, and it shows that parents of children in years K to 2 and 4 were asked whether they considered their child to be very underweight, slightly underweight, about the right weight, slightly overweight, or very overweight. And parents' responses were examined against their child's actual BMI. The first thing we could see was that in about 85% of parents of children who were in the healthy weight range were able to correctly perceive their child to be about the right weight. Those who didn't perceive their child to be about the right weight actually thought their child was slightly underweight at about 13%. The second interesting point to see was that in children that were above a healthy weight, only 73% of parents of children above a healthy weight perceived their child to be about the right weight, which really highlights for us in practice how we can approach this topic with parents, as not all parents are perceiving a problem. And finally, almost a third of parents of children well above a healthy weight perceive their child to be about the right weight, and just 60% of parents felt their child was only slightly overweight. Again, this poses a challenge for us when raising the issue. It also highlights the need for the role of the health professional as educating parents. It shows that parents will need assistance when trying to perceive if their child is above a healthy weight, and otherwise the child may miss out on the appropriate health interventions. Okay, so now that we have had a look at and hopefully understanding some of the issues parents and families are facing, let's see what we can actually do in practice. This is looking at using the 4A's approach, which is highlighted on the Healthy Kids for Professionals website. It's a new resource developed to support GPs, and hopefully some of us are already familiar with it, supporting GPs and health professionals to raise the issue of overweight and obesity with parents. It follows the 4A's approach of assess, advise, assist, and arrange. On this website, you can find a variety of resources, including the BMI for age and gender charts, fact sheets for families and parents, weight status calculators, and there's also online learning module. It's free access for everybody, and it also contains multilingual fact sheets and many translated resources. So the first thing we want to do is assess the impact. And then we'll move on to some cases. We summarise, children from a lower socioeconomic background, culturally and linguistically diverse backgrounds face challenges across a number of areas, including less financial means or resources, for example, to eat healthy, to exercise or seek medical interventions, especially if you're in a lower socioeconomic background. They may face barriers to access, such as regional, rural areas and experiencing vast distances to services. Language barriers and cultural perceptions of the health system are all complex issues. Families may have limited understanding of diet and nutrition, especially when moving from a traditional to a Western diet, and how we need to know how we can help manage this in practice. And finally, environmental factors such as family, culture, and home environment, the convenience of modern technology, fast foods, and other contributing issues such as mental health and other health issues, as well as looking at the built environment. Is the suburb have any ability to walk to fresh food? Or are people relying constantly on cars and things like that to access?
Before we move on to the case studies, Natalie, there's been a couple of questions that have come through. So there's one asking about why we continue to use the diagnostic descriptor obesity. I think the Pro Healthy Kids website that you've just spoken about and the percentiles that we went on earlier, we're really being encouraged now to use above a healthy weight instead of that. Is that correct?
Yes, that's right. Through all the research that's been conducted, the language has been changed to language that parents feel more acceptable. We know that the terms obesity, when used with families, has quite a negative connotation, and it's often perceived as quite judgmental. So using the terms under a healthy weight, well above a healthy weight, or a healthy weight is, the most appropriate way we can start speaking to families about these issues. And it's been studied with families and children that they find this language acceptable, easy to understand, and yes, going forward, these are the types of terminology that we should be using.
Fantastic. And we had another question come through. Do we know anything about genetic factors that play a part in above a healthy weight in children?
Through the research, we've mostly seen that it's environmental factors that affect children's weight, such as their intake of soft drinks, fast foods, whether or not they're meeting their physical activity requirements. So that is the most important thing that we can really focus on when trying to deliver appropriate healthcare to patients from all backgrounds and all families.
Fantastic. No worries. Let's move on to some case studies then.
Thanks, Natalie, for going through all the statistics and setting the scene for the second half of the webinar, where we'll go through 2 case studies. And so these 2 case study subjects have had their name changed. They are real life case patients. So we'll like to make this half of the webinar as interactive as we can. So feel free to type in your questions, and we'll endeavor as much as possible to bring them up and go through them as well as keep to the time limit. So we'll just start with Isaac here. Isaac is an energetic 4-year-old and 4-year and 4-month-old boy who comes to practice for the first time. He is accompanied by his grandmother, Celia. She tells you she wants to get his immunizations up to date, as he and his 2 older brothers have just come into her care from their mother due to issues of neglect. Celia would like Isaac to have his 4-year-old immunization, as she has a letter from Centrelink stating he is not up to date with his childhood immunizations, and she is worried he won't be able to attend preschool without them. Whilst talking to Celia, it's noted that Isaac may be above a healthy weight. What else would you like to find out at this point? If anyone has any comments, please send them through.
So I think whilst we're just waiting to see if anyone's got any comments or questions to start with, I think the most important things that we should try and find out at this point, as we've just met Celia and Isaac, is are there any other factors going on? Is there carer stress for grandma? Is their financial stresses or other competing priorities? Maybe as we've seen that missed childhood vaccinations is a common reason for children to present to general practice, but it's a really vital and important role that we use this opportunity to conduct a more comprehensive health check at this time and find out a bit more about Isaac's developmental health, and how he's been going overall. So I think the next things we would like to find out is a bit more in his background history, birth history, and how he's been going to date, to find out if there's any more issues we need to discuss with Celia before just giving his vaccinations.
Yeah, and we've had some great responses come through asking that question about what can we see arising from this case. We've got people asking about family background, diet review, socioeconomic status. Does Celia think that Isaac's weight is a problem? Birth history and milestones. There's lots of stuff coming through there, so that's great.
In terms of past medical history, he was a term baby born via C-section. Mom's pregnancy was complicated by maternal hypertension. His birth weight was 4,000 grams, I beg your pardon, 88 percentile. He had a short admission to NICU for transient tachypnea of the newborn. He was mostly bottle fed and started solids around 6 months of age. Celia reports he has a history of intermittent asthma, often triggered by viral infections, recurrent otitis media, and he is a loud snorer. She's also worried about some of his development. She tells you Isaac finds it hard to sit still and gets easily frustrated with other kids and have a limited vocabulary compared to his brother at the same age. He has a suspected peanut allergy, but no formal testing, and medications include salbutamol 2 puffs as needed. Already we can see there are multiple issues in this child's initial presentation. What are some of the issues we can see here?
So if you can send us through via your chat box, let us know what you can see some of the issues might be in this initial presentation. Sleep apnea, overuse of steroids.
Yep. So everyone's making some really good comments so far, and I think picking up on some important issues here. So we can already see from the history that he had a large birth weight, so that's placing him at risk of other health issues later in life. There was a risk of respiratory illness. He was in NICU for TTN. He was bottle fed, so there may be issues there. We also can see that he's got asthma, so we probably need to start thinking about is his asthma well controlled or not, and do we need to check things like inhaler technique? Does he have an action plan, for example? Grandma's also mentioned some symptoms suggestive of obstructive sleep apnea, and as people have mentioned on the comments, and we'll need to start looking into an assessment for that. As well as that, Grandma's mentioned some issues regarding developmental concerns, such as possible language and speech delay. She's also reported he's suffering from recurrent ear infections, and possibly there's a fusion. Maybe he needs hearing testing, vision testing, and maybe a referral to ear, nose and throat specialist, and at some stage a paediatrician. We probably also need to think of some of the psychological and psychosocial issues. If there's been some trauma in the family, that would be really important into looking into Isaac's development. And already we can see that this case is going to be much more complicated and complex, and have much more for us to deal with than just administering his childhood vaccinations.
Okay, moving on to the family history, there is type 2 diabetes. That Celia has been diagnosed with hypertension for mom, asthma, and eczema of his brother. In terms of social history, and someone has asked his ethnic background initially, Isaac is of Cook Islander background, born in Australia. Parents separated and lives with his grandmother and 2 elder brothers. Mother visits regularly, but grandma looks after his care, goes to playgroup once a week. So at this point, we'd just like to ask the audience, what issues could there be arising from his social setting that could potentially increase his risk for childhood? I was gonna use the word obesity, but now I'm just stopped myself and I'm gonna say above a healthy weight. Pose a challenge for management as well.
Yeah. And that's true. It's a term that we are used to using in the past, and it's something that as health professionals we should get used to using the new language as much as possible, especially when dealing with parents and families. People are putting through some really good comments so far, which is great. I think some things that we would like to just think about in this case is we know now that he is from a Pacific Islander background and a cold background, so he may be at a raised risk of being above a healthy weight. We know from the suburbs that he lives in and that they're living in an area that's of a lower socioeconomic status, in a higher area of high proportion of fast food outlets to fresh food. For example, in Western Sydney, takeaway outlets have outnumbered fresh food for about 3-to-1 ratio in about 28% of neighbourhoods, and that's from a study from Wollongong University. We can see from his family history, as people are pointing out, that he might be at risk of metabolic syndrome and type 2 diabetes, and we need to have a look at things like asthma, eczema, all of those factors. We should also take into account, if grandma is his main carer, she probably has her own health issues to deal with. She might be having stress relating to managing her own chronic and complex conditions, and we need to find out, does she have any extra, motivational support to help with Isaac's potential health issues that we are starting to see it come to light. And if she doesn't have enough support for this, we need to find out who could help. Is it other family members available, or can we look more widely into the LHD? For example, there might be child and family nurse support available for her. We noticed that they've mentioned that he only goes to playgroup once a week as a preschooler. That might not be, him. What is he doing on the other 4 days of the week? We think that he might not be meeting his physical activity daily requirement of at least an hour per day of moderate to vigorous activity, and we should inquire a bit more about what he's doing on those days where he's not at playgroup. And as we saw in the SPANS report data, that was a very interesting point, was that a lot of parents didn't actually know what the recommended daily physical activity rate was. So about half of parents didn't know that 60 minutes was required for most children. Okay, so following the 4A's approach, we want to look, this is based on the Pro Healthy Kids website, and we want to start with assessing Isaac a little bit more. So firstly, his examination findings: his alert, well, running around the office, his heart and chest were all normal, but he had bilateral dull tympanic membranes, and his throat showed enlarged tonsils bilaterally. As part of a routine examination, we weighed and measured and found that his height was 120 centimetres, his weight 32 kilos, and the calculated BMI was 22.2. So based on this information, we now want to find out, what does that BMI mean, because we know that BMI changes whether or not you're above a healthy weight, or a healthy weight is related to your age. So we need to then have a look at the BMI for age charts. So these are the BMI for age charts for boys and girls, which can be found on the Pro Healthy Kids New South Wales website. They are they've been designed to be easy to read. They are colour-coded to help display the information to parents and families, and especially to those with maybe lower health literacy and not maybe as English is not their first language. Again, it uses the language of below a healthy weight, less than the 5th percentile, healthy weight 5th to the 85th percentile, above a healthy weight 85th to 95th percentile, and well above a healthy weight, which is the 95th percentile and above. So we should try and use these resources as much as possible in practice, and they are all available on the Pro Healthy Kids New South Wales website. So as we go on, so we continue our assessment. So as you can see on the chart, we've plotted Isaac's BMI of 22.2, and it places him well above a healthy weight for his age, as you can see with the arrow there in red. So we think, well, we better discuss this further with Celia, as it's part of our role as GPs to try and discuss how being above a healthy weight will have implications for the child's health later in life. And we want to, try and help families and carers understand this. Most important to note that we don't want to just rely on a single measurement in time. We'd like to be able to measure children routinely as part of regular clinical practice and start to assess the trend of their growth. And that's going to be the most important factor to understanding, how they're going and how they're progressing. So the next thing to do is we'll try and start a sensitive discussion about Isaac's weight status being above a healthy weight. If anyone from their practice or from how they work has any comments or suggestions regarding how we could approach this, please feel free to send them through at this time. Everybody would have a different way of going about this. And there are many ways we could initiate this discussion. One possible way that we thought of was that we could offer the BMI chart to Isaac's grandma so that she could see visually where Isaac was placing is above a healthy weight category. We wanted to explain to grandma that we've assessed his weight and we found that his BMI calculated shows that his weight is in the range of well above your healthy weight. We want to ask her, does she have any thoughts about this? What does she think about it? Does the information surprise you, or was she aware that there was a problem in this area? And definitely giving her time is very important, and finding the amount of time to discuss it further. Today's visit might not be the appropriate time, but we would like to offer her more time to discuss this issue, as being above a healthy weight is likely to have implications for Isaac's health in the future. And we want to explain to her that it's our role as GPs to try and raise the issue with family members so that we can all work together as a team to help Isaac get back into the healthy weight range and help him to grow up healthy and happy. So the next thing is we'd like to try and work on building an ongoing relationship with the family so that we can start prioritising these complex issues and following up as appropriate. And I think that's some of the comments that have come through to give patients lots of good follow-up appointments, to give them time to process the information and to follow up and find out the trends. So over the next few consultations which we arranged, we were able to discuss that children above a healthy weight can develop other health problems in childhood, such as asthma, sleep disorders, hip, knee and ankle problems, and things like high cholesterol and high blood pressure or metabolic syndrome. We also know from the data that children who are above a healthy weight were also more likely to become overweight as adults, putting them at risk of health problems like heart disease, diabetes and cancers. So when we had appropriate time for follow-up, we were able to discuss with Celia that she was able to do a lot to help the family to develop healthier eating habits and keep them active and keep the whole family active and well. We were able to advise that they're not on their own to do this, and we're here as a team to help make changes to help Isaac get back into the healthy weight range for his growth, and also to advise that children's growth can change over time. So that's important that we keep following up, keep reviewing his height and weight regularly, and to monitor the trends, not to use one measurement in isolation. We also wanted to point out to her and discuss with her that there's plenty of options and to help improve Isaac's health, but the first and the best thing to do is start off with things that you can do together as a family, and that's definitely a more effective way of changing if the change is family-wide.
Natalie, we just have a good question that's come up, and so someone in the audience asked, do we use these charts for all the children regardless of their race, birthplace, etc.? That would be a good one.
Oh, yeah, no, that's a very good question. So these BMI for age charts are developed from the CDC, the CDC BMI for age charts, and when they developed these charts, they used data from children from all backgrounds and ethnic backgrounds, and they found that the overall rate of growth can be expected to be the same for children no matter what kind of ethnic background they came from, and that the most important factors were things like the environmental factors like diet, exercise, and sedentary lifestyle and things like that. So yes, we can use these charts across all children. They've been established for that reason.
That's good.
So the next thing we want to do following the 4A's approach is to help assist in, this is using the 8 for a healthy weight chart, and hopefully everyone's seen this already, but if not, we'll go through it. So after we've gone through the process of assessing Isaac's weight for age and advising his grandma Celia that he is well above a healthy weight, she wants to know what can she help to do to improve Isaac's growth to make him more healthy. So we said, well, this is a very simple and straightforward way that she can help her whole family develop healthier eating habits and keep them active and well. So this is the 8 for a healthy weight chart, and has 8 simple strategies that families can do together to help improve the whole health of the whole family. Things like drinking water instead of juice, cordials or soft drinks, increasing vegetables to at least 5 serves a day and 2 serves of fruit per day, trying to start the day each day with a healthy breakfast, knowing portion sizes and serving sizes, that's really, and sticking to those sizes, changing the snacks from more treat foods to more healthier snack food options, limiting screen time to the recommended times per day, and increasing physical activity for up to at least an hour a day for all kids. Most importantly, getting enough sleep. All kids need the appropriate amount of sleep. And most in the middle, it shows to do it all together as a family. The main thing I think to try here is to try and use some motivational interviewing techniques to find out what Celia or the family member thinks that they can actually do, what's going to be realistic for their family, and what do they think is achievable, and then I think we'll start to get some success. And also on the Pro Healthy Kids website, this is available in multiple translations, for example, Arabic, Vietnamese, and many other languages. So you just need to go to Pro Healthy Kids to find that. Okay, so after making sure that Isaac's 4-year-old vaccinations were up to date and completed, which was his presenting issue, we continue with our follow-up visits with Celia and Isaac to see how they are going with some of the simple changes based upon the 8 for the Healthy Weight guidelines. We want to try and provide as much support as possible at this stage so the family feels supported, so regular follow-up visits will help. We also note that there's other, as we've discussed throughout the case so far, that there are other health issues that we would need more time to assess, such as his asthma control, symptoms such as his snoring and is it linked to sleep apnea, and his grandmother Celia's concerns about his behaviour and development. So I think getting the appropriate follow-up is important, and it's important to note, just finally for this case, that whilst children who are above a healthy weight tend to have more complex health conditions, the studies have shown that there is a direct healthcare cost for children with obesity or being above a healthy weight, aging 2 to 4 years, were at least 1.6 times more likely to spend more on health, to need more spent on their health. So there's a direct link between being above a healthy weight and those other health conditions. We just put on the slide there, we could also use Get Healthy service to support the carers and Celia in this case, and using your your medical program recall system to try and be systematic in the approach of following up the family is important, and to try and engage the whole care team. And that may be different depending on your setting. You might have practice nurse or allied health or community child and family nurses, but to try and make the family feel as supported as possible is really important.
Thanks for your questions that are coming in. So we have a few questions about nutritional guidelines, and we'll go into them a little bit later as we proceed into our next case study. And this case study is about an 80-year-old boy called Danny, who's known to the practice, brought in by his grandfather with an ankle pain. Danny was playing at lunch when he rolled his ankle. It was instantly painful and difficult for him to walk on, and it's now a bit swollen. His grandfather, who always picks him up after school and looks after him until his mom gets home, is worried it might be fractured. His medical history is significant for recurrent impetigo and frequent episodic asthma, lots of asthma in the country right now, allergic rhinitis. Immunizations are up to date. Medications include Flixotide twice a day, Ventolin Q4 hourly, and Nasonex Junior. No known allergies. What issues might be important at this stage?
Okay, so if anyone's got any thoughts, please send them through. But some things that we already can see from this case is that being above a healthy weight may be associated with things like poorly controlled asthma and musculoskeletal conditions. And also there might be some social factors in this family setting as well. Again, Danny's mostly in the care of granddad. Parents are working long hours. So we need to find out a bit more about what is his routine like at home. Is he meeting physical activity levels, and how is his dietary intake looking?
In terms of his family history, Maternal grandmother has type 2 diabetes. Sister has asthma and eczema. Social history. Parents were born in Australia from an Egyptian background. His parents have recently divorced and his mom has remarried. Her new partner is of Samoan background. He has one elder sister. His maternal grandfather provides the majority of his after-school care whilst mom works and is often and grandfather attends medical appointments. He attends year 2 at the local primary school.
And again, just issues to note here. He's of a background where we already have seen from the data that he's at risk of being more above a healthy weight. Multiple languages are spoken at home, and there's family history risk factors for things like type 2 diabetes, as well as psychological and psychosocial stresses like he's witnessed his parental breakup. He might be having mental health issues as well. And we want to also find a little bit more history.
Danny's grandfather asked if you can check Danny's growth, as he's worried that he's above healthy weight, and asked if his ankle injury could be related to his weight. Danny has also reported being teased at school about his size. He eats a healthy snack with grandfather in the afternoons after school, but when mom and stepdad gets home late from work, they often get a takeaway for dinner. Example, chicken and chips 3 to 4 times a week, and they have a can of soft drink with dinner. He is also not meeting his daily requirements for physical activity. He does not like sport and prefer to read or play video games. Grandfather is worried about his self-esteem as well as effects his weight might have on future health.
And again, there's lots of issues here with the high amounts of takeaway food intake being associated with being above a healthy weight, which we saw in the SPANS data, not meeting vegetable intake and not getting enough physical activity a day. He's also having a high amount of processed food, and that all might be factors for Danny. So next, as following the 4A's approach, we would like to assess him, same as we did for Isaac. So we've got his height, weight, and calculated BMI there. We also note, as we examine him for his presenting issue, he's got an antalgic gait, he's got some left ankle swelling, and he's tender over the lateral malleolus. But importantly, we do note that there's some signs of acanthosis nigricans around his neck.
Just a question to the participants to get them thinking. Given the family history and examinations, what would you be concerned about right now? Yeah. So we have people writing in concerns about diabetes.
That's right. Yeah, there's a high risk for insulin resistance, pre-diabetes, and metabolic syndrome. So we'll go on to continue to assess how Danny is going. We're using the BMI for age charts from the Pro Healthy Kids website, and again we've plot his BMI for age and find that he is placed well above a healthy age. So we want to maybe show Granddad this chart, and as Mum and Dad and Stepdad aren't there today, we suggest maybe he could take this home and bring the whole family in together next time for a more detailed chat, as well as after we've sorted out Danny's ankle injury. So when Granddad mentions that he's not sure if the rest of the family will be able to get involved due to their work commitments, but we'll do our best. He will do his best. We tell him that we'd like to discuss Danny's being above a healthy weight due to the implications it can have on his health later in life. So hopefully he can get them to come back in, and when he does, we'll have a chat with what we can do to assist him further. So again, we can use the 8 for a healthy weight chart with Danny's grandfather and his family, and we were able to get his mum and stepdad in at future visits. We were able to use this framework to make simple changes that the whole family could do together. In this case specifically, we tried to help see if the parents could provide a focus on providing more healthier snack food options and lunchbox options and increase his fruit and vegetable intake. We also discussed how we could reduce takeaway foods to fit in with their busy schedule, and with that try to reduce his soft drink intake. We tried to look at swaps. For example, his lunch used to be a white bread sandwich with some kind of spread, like a Vegemite or jam. We discussed how could we change this to maybe wholemeal bread or salads or things like that. We also tried to educate about appropriate portion size, and again, arranging regular follow-up within a month so they could come back and discuss this further. And the 8 for a Healthy Weight is really, really useful framework for discussing what approach we can take with families, especially if they're in lower socioeconomic area or rural and remote area where more health services are not available. So again, we tried to arrange more follow-up, and we wanted the main goal to be to get the whole family involved in taking part and to keep following up until we got that family engagement. We considered referrals such as Go for Fun for Danny and the Get Healthy service, which is providing advice and support for his parents and family. And in this case, we see that Danny has chronic asthma, so he would be eligible for a team care arrangement and a GP management plan. And so we were able to arrange this for him and provide referral to our dietitian, who was part of our care team, who then she could provide even more advice and follow up with the family.
Oftentimes in my practice, I found it's so helpful to work with a dietitian to provide dietary advice for different kind of chronic conditions, including weight loss, diabetes, and even chronic renal disease. So also they're really capable and skilled to provide really good advice. And we do know that in some communities, like outer regional communities, they might not be accessible to getting a dietitian review. And so we have come up with a few resources that could offer some brief dietary advice as well. So the ones that we have found would be the Australian Dietary Guidelines available on the NHMRC website, have great pictorial serving sizes for each food group, and also healthykids.newsouthwales.gov.au has some great resources. And I know of another one just off the top of my head called raisingchildren.net, also has really, really good nutritional advice, and actually according to different age groups as well. So there are resources out there for or GPs who can't seem to get their patients to see a dietitian for whatever reason, whether it's affordability or because the resource is just not available. There will be some guidelines available for help. Yeah.
And lastly, we'd just like to go into a little bit more about some things we mentioned in the cases. So the Go for Fun service, which is a free healthy lifestyle program for children in New South Wales aged 7 to 13 years who are above a healthy weight or above the 85th percentile. Parents and carers do need to be available as they attend a parental session, while the children attend a session with physical activity activities. They learn things about nutrition, appropriate physical activity, behavioural changes, and family changes. It's all free, and it's usually provided during term times, so it goes for about 10 weeks and delivered by a dietitian or exercise physiologist or other qualified health professionals. It's got a really great reach so far. Over 1,000 programs have been run already across New South Wales, reaching about 11,000 families. And the stats from the program show that there has been improvements in BMI by at least 0.5 kilograms with BMI, and waist circumference has reduced, and they've also noted improvements in children's physical activity levels and general nutrition levels. And importantly, it's free and can be accessed by families in lower socioeconomic areas. It also runs as an online program for those in rural and remote areas, and there is the Aboriginal and Torres Strait Islander version for patients and families from Aboriginal and Torres Strait Islander background that has got Aboriginal support staff and links to traditional food, games and resources.
And we've just had someone comment that the program is not available in north of Tamworth, sorry. So Go for Fun now has an online program as well. What I will do in the resources that we send out tomorrow, I will send you links to our Go for Fun webinar that we ran that outline all of the services available, both face-to-face and online.
And just, it's really important for GPs to make the referral. All the information for how to refer is here on the slide. If GPs refer, they will get feedback from the Go for Fun program, which is really important in closing the loop for communication, so that we know what's happened to our patients and families when we've sent them out into the program. It helps families take up the program if the GP refers, as like we said before, GPs are a trusted source, so parents and families are more likely to take up the referral if it's made through the GP or the practice nurse or someone else in your care team. And finally, the Get Healthy service, it's an information and coaching service which is run over the phone. It's for everyone aged 16 and up, and it provides coaching calls to help with patients to get motivation, to make goals, and improve things like their physical activity, weight management. They can look at programs for reducing alcohol intake, and there's also a program for gestational diabetes. It's a really useful service, and if GPs refer, we will get a report back from the Get Healthy service for how your patient went. Just important to note, there are resources for patients from culturally, linguistically and diverse communities. There is a use of a translator and interpreter service, and 20% of participants were from CALD backgrounds. They are also trialling a bilingual coaching model and a coaching model for Aboriginal participants using an Aboriginal liaison officer to try and make the program culturally appropriate for everybody.
Alrighty, so this is just reviewing the learning outcomes that we went over at the beginning. So we hope that now that we've come to the end, that you will go away being able to do these things. I'd like to thank our presenters, Jessica and Natalie, very much for joining us tonight. I hope everyone online enjoyed the session. Thank you again, Natalie and Jessica, for joining us, and good night, everybody.
Thank you.
Thank you for having us.
Thank you all.